This short video highlights features of long-term catheterization not normally seen by the clinician. After 3 months catheterization, the bladder will inevitably be colonized by bacteria. And apart from trauma, infection accounts for all the complications that may arise. A flexible cystoscope has been passed through the urethra. With the end held at the neck of the bladder, the tip and balloon of the suprapubic catheter are clearly visible. Inflammatory debris can be seen floating freely around in the urine, producing an effect rather like a snowstorm. As the bladder empties, the urothelial lining of the bladder wraps around the catheter. This view of the catheter tip shows the inflamed edematous mucosa, the biofilm on the surface of the catheter, and debris in the bladder base. Note how the mucosa is being sucked into the eye holes of the catheter, forming pseudopolyps which can obstruct the lumen of the catheter. This arises from the negative pressure which develops in the drainage tubing from the unbroken column of urine above the urine collection bag. If the vertical height between the bladder and bag is 30 centimeters or more, the suction effect can be dramatic. Watch as the bladder empties and note how the mucosa is suddenly sucked into the eye holes. And then, on refilling, the bladder has to become quite distended before the vacuum is overcome and the mucosa is released. When a catheter repeatedly blocks, cystoscopy becomes obligatory. This 85-year-old lady underwent 3 catheter changes in 3 days. Cystoscopy revealed the tip of the catheter embedded in the wall of the bladder, with the eye holes completely obscured. The balloon is deflated, but note how its walls form folds, which can occasionally produce a cuff, obstructing the catheter removal. Gentle rotation can help its withdrawal, and this releases the blood and mucus trapped around its tip. A deep cavity is exposed where the catheter tip had penetrated, but fortunately not perforated, the posterior wall of the bladder, which can be thin in women. As the catheter is removed from the bladder through the suprapubic cystostomy, thick inflammatory mucus can be seen pouring out from the lumen of the catheter. The suprapubic tract first passes through the bladder wall, and this can contract quite rapidly within a matter of minutes, so that it becomes impossible to reintroduce another catheter. Any delay in replacing the catheter should be avoided. A new catheter is introduced. The clean, smooth surface and rounded borders to the eye holes are designed to minimize the risk of encrustation and trauma. The balloon is filled with 10 milliliters of sterile water. Recurrent blocking of the catheter should alert the clinician to the possibility of bladder stones, invariably associated with urease-producing bacteria, such as Proteus mirabilis, which become entrapped in the stones and provide a constant source of reinfection. The dome-like structure indicates operative closure of the urethra had been performed to prevent urinary leakage. The stones consist of struvite and hydroxyapatite crystals, which can be quite soft and friable. Any attempt to remove stone fragments with grabbing forceps merely breaks them into smaller fragments, whilst the time-honoured dormier wire basket remains a slow but safe way of extracting them. If left, small stones grow into large ones, demanding more aggressive intervention. If a catheter is repeatedly blocking, a cystoscopy should be performed to check for stones. The self-retaining balloon catheter was introduced by Dr. Foley in 1937, and despite the high morbidity, it remains the conventional method for continuous long-term drainage of the bladder in men and women. Perhaps one day modern science and technology will introduce a better urine collection system to help these unfortunate patients.